Good morning, everybody. Supervisor Yeager and Supervisor Smidian, I really want to thank you for the opportunity to give feedback and update you on what we're doing with nursing. Over the past couple months, nursing administration has been working collaboratively with RNPA leadership to really look at the data and look at what we're doing in regards to recruitment. And during that time, it's very apparent our goals are aligned. I think we both want the same things: the ability to hire experienced nurses, of course, retain top talent, and really create a structure and infrastructure for professional growth for the nurses. Of course, encouraging advanced practice. That is the new horizon for nursing. And we are really dedicated to training new graduates. We need to invest in our workforce, depending on what you read and what part of the country you're in. In parts of the country, the nursing shortage is here. California hasn't been hit as hard, but we are anticipating a large number of experienced nurses leaving the workforce with our aging baby boomer population. So we really need to invest in new grads. And my goal as a CNO is I want everyone to flock to VMC and just be the employer of choice, like Google is to the tech industry. And if we look at year over year, as our average daily census has grown, our outpatient clinics has grown, we have added positions. And so over the course of the past 3 years, we've added additional coded funded positions. And if we look at our vacancy rate, we are making progress. We recently, thank you very much, added 47 additional clinical positions to help with our ICU bed expansion, the ED, and the operating room. And despite, if you look at the top graph, in July of 16, we were at about a 9% vacancy rate, and currently we're running about 7.52. And
Jill, I'm just going to stop you there. And how does that compare nationwide?
Well, nationwide is anywhere from about 6% to 18%. But here in California, UCSF did a study about nurses in California, and the rate in California is 11.6%.
And again,
that's turnover rate. But again, we're under for turnover and for vacancy rate in California.
Great.
So underneath that is custody, and Matt Guerrier couldn't be here today, so I can certainly report custody is higher than inpatient, ambulatory, and psych, running at about 16% vacancy rate. As far as why people are leaving, it's very important to us if we do have coded people that are leaving, why they're leaving. And so in 2017, we started doing exit interviews, and the breakdown of, can we go, sorry, go back. We did have 52 nurses retire, which is a good thing, but unfortunately it's at a much faster rate than in prior years. And 80%, well, I guess fortunately, or unfortunately for us, but 87% are experienced nurses, are Clin 3s. And our annual turnover rate of 6.8. You can see by the chart here, the majority of nurses leaving are clinical nurses. Okay, now we go to the reasons. So when they started doing the exit interviews, they wanted this to be confidential so we could get truthful and accurate information. And we looked at the top 5 reasons: family obligations, changing to per diem status. So they stayed within the county, but they wanted more flexibility in their life. So we didn't really lose them, but we lost them as coded employees. But they stayed with us per diem. Unpleasant work environment, and unfortunately that's kind of a broad statement, so we don't know if it was peer-to-peer or if their manager or just the patient, the clinical area they're in. The fourth was kind of tied with the third: work schedule, work-life balance, depending on the shift in the code. And the fifth reason was moving out of the area. And I know of specific examples. People are going to Oregon and they're going to Las Vegas because the cost of living is so much cheaper and the housing market is pretty hot here. So We absolutely depend on our extra help and per diem nurses to help provide a flexible staffing model, because we need the ability to maybe flex up by a census of 40 over 2 shifts and flex down if we have a lot of discharges. So many hospitals actually run on an 80-20 model, meaning 80% of their nursing hours are from coded benefited employees and 20% are agency, per diem, and extra help. We run closer to a 90-10 model, meaning 90% of our staff are coded, and that 10% of our per diem and extra help actually are extra help and per diem hours. So we're averaging about 9.9. And if you look from January of 17 to February of 18, the 2 highest months of extra help utilization was November, in which we were doing a lot of training and planning for the opening of Sproul, and we had to backfill for education. And then, of course, February being the worst flu season in a decade, so we had a very high census. If we look at how do our extra help nurses fare with going into coded positions, of 122 new hires for calendar year 17, 87% were extra help or per diem, which is really a win-win situation for us because they don't require any training, orientation, and it's a way to help retain them into a coded benefited position. This is for custody. They hired quite a few per diem nurses, and they hired 46 actual extra help and per diem, and they had 15 leave, and they were able to get some into coded positions. Again, any questions for Matt, we can certainly defer when he's able to answer them. Recruitment of nurses. I'm happy to say a couple years ago we were able to add some resources. So we have someone that's a whiz at social media, which is just widening our, everyone goes online now to look for jobs, not like when I was looking for a job. And so the use of, Twitter and Facebook and all these efforts has really helped with our applicant pool. And so this data was provided by Nursing Recruitment, and if you look at the CLIN ones, we do not have any problem with 1,800 new nurses applying to VMC. And you can see from before social media to after in the CLIN 2 area, we've really increased our CLIN 2 applicant pool, and we're kind of staying steady with our CLIN 3 applicant pool. But that's not unusual. I meet with all the CNOs in the area quarterly, and the experienced clinical nurses is an area that people are having difficult with, specifically OR, ED, critical care. But we have had some success, and we are able to hire experienced nurses. Our OR manager has just recently hired 6 experienced OR nurses, 2 with 20 plus years of cardiac experience, which is unheard of. And our manager of CCU and MICU has just been able to hire 5 very extremely experienced critical care nurses. So we're very proud of our training programs. Being a teaching hospital, we do train a lot of nurses, and our medical surgical training program and critical care training program has been around for decades. The training involves for med-surg, 8 weeks, that's minimum. And for critical care, it's longer, 12 to 16 weeks. And I have to say I'm a little biased with our critical care training program, as I'm a product of it from 1990. So I can vouch it's a very good program. And I know the costs of training were asked in the March Board of Supervisors meeting. And so if you look, it does cost about $30,000, and these are just direct costs. When we met with RMPA, there are a lot of indirect costs. They're hard to put a figure to, but RMPA leadership really wanted to make sure that I addressed that we can't just look at the direct costs, because when new grads get off orientation, they can't take as much of a load. Their time management skills are still developing. They can't take as quite as high of acuity level. So again, the costs do vary depending on experience and clinical setting. Our future plan is, again, to continue to work collaboratively with RMPA. We really need them at the table. It's we. And we did find we do have a deficit that we don't really have a formalized recruitment and retention committee, so we are going to be forming one. And the membership absolutely has to have frontline staff. It's so important that we have their voice at the table of what's working and what's not working, also including nurse recruitment, of course, nursing leadership, and our clinical educators. We are also going to be doing focus groups for our new hires. Nurses that are in the first 6 months to a year, again, really sitting down with them and how can we better our program? We've reinstituted the unit shared leadership for inpatient. All of them are up and running. And as far as shared leadership, it's so important as a CNO that nurses at the bedside have input into decisions about their practice, their work environment, and it really increases nurse engagement. We've also been successful with having some house-wide or division-wide cross-functional teams that are working in critical care, med-surg, and maternal child health they're working on issues that affect all aspects in their division. We're going to be instituting the hospital-wide shared leadership, so nurses will have an ability to participate in hospital activities and not just their unit activities. Again, we have made a really mindful effort to work on positive employee relations, and nursing administration launched a kindness campaign in September to really set the tone for a respectful, kind environment. Of course, being kind to our patients, but people need to be kind to each other. It's kind of taken off. We have to keep it on the forefront of all of our communication. Employee wellness is a hot topic, and I know Paul has had lots of conversations with executive leadership of how important it is to invest in our employees and employee well-being, and I know that's a priority for the county. But we really want to have a subgroup out of the nursing recruitment that's really looking at a nursing well-being specific to nursing. We've launched a Code Lavender, which is a structure to support nurses after a traumatic event, whether it's a code situation or a child death, that they can really have support immediately. And I'm really happy to say that we piloted a mentoring program in the pediatric intensive care and the pediatric unit, which has been very successful, and we're rolling it out to critical care. So our 52 either new to critical care or new grads into critical care that we just hired are going to be our test group to really look at retention and how having a formalized mentor really helps with retention. And lastly, with also the voice of RMPA, we've requested additional FTEs for our float pool, which again, the resources will be to help with additional rapid response nurses, with creating a float pool for ICU, step down, and med-surg, and also vascular access, so we can put the resources to the frontline staff and better support them. I know that was a lot, so I'd like to take any questions or clarify anything.
Thank you, Jill. I think what we'll do now is hear from the public.